Good morning. I will present this session about a child with bleeding symptoms for fifth-year medical students instead of a clinical session that is supposed to be taken in the hospital, because of the current circumstances of COVID-19 pandemic. And I try to mention important points in history taking and tips on examination. I hope it will be useful for you. Regarding history of a child with a bleeding tendency, you know that bleeding symptoms it can occur in healthy children and may not necessarily suggest a generalized bleeding disorder. For example, epistaxis might be caused by rhinitis, trauma, oozing from superficial vessel or dry air. But symptoms that occur with unusual frequency, duration, or severity, we should always consider underlying bleeding disorder. Also, an abnormal post-surgical bleeding, for example, after tonsillectomy, circumcision, or tooth extraction, it may occur simply because of surgical trauma, but it may also suggest possibility of underlying bleeding disorder, especially if the child has had a previous history of bleeding symptoms. So a clinician always should be alert to possibility that bruises or bleeding are judged to be abnormal depending on many factors like frequency of the attacks. When it occurs frequently, it means that there is something abnormal. Duration, whether for how long these symptoms are present. Also severity of the episode. For example, there is lack of explanation for symptoms or physical finding that may be caused by bleeding disorder or maybe by non-accidental injury or child abuse. Therefore, in the history, we should assess the degree of symptoms and the severity by looking for the nature of a provoking injury and whether such injury is consistent with the child level of activity. Sometimes mild trauma causes a severe bruising or bleeding, which is suggestive of abnormal bleeding tendency. So during assessment of patient bleeding history, it is very important to ask about a previous bleeding episode, whether the child has a previous attack or this is the first attack. Also to characterize the type of bleeding and the site of bleeding. For example, bleeding in the skin and the mucous membrane, always characteristic of a platelet disorder and their interaction with the blood vessel. That's to say purpuric disorder, which may be manifested as fatigue and or ecchymosis, while bleeding in soft tissue, muscle, joint, suggestive of underlying coagulation disorders, for example, hemophilia. Family history is very important to be concentrated on in taking history of a child with a bleeding tendency. Inherited bleeding disorder should be strongly considered when the onset of a bleeding manifestation occurs in early infancy or early childhood, especially if there is positive family history. However, we should raise this point that sometimes when inherited bleeding disorder is mild, it is not necessarily to present in infancy. It might present later in life, because it is a mild disorder. The presence of bleeding manifestation only in male sibling and maternal uncle, al-akhwal, is suggestive of X-linked recessive inheritance. For example, an inherited coagulation disorder like hemophilia. However, 1/3 of patients with hemophilia, they might have negative family history. Usually the mother is a carrier, so she transmits the abnormal X chromosome to her son, and her brothers are also affected. While in the cases of von Willebrand disease, the transmission is an autosomal dominant fashion. While in autosomal recessive disorder, the family history may be negative. In these cases, consanguinity increases the probability of such disorders. Medication also should be asked for, especially herbal medicine, because, you know, in our culture, many people are using the traditional herbal medicine. Also, ingestion of aspirin containing over-the-counter medication or non-steroidal anti-inflammatory drugs, because aspirin and non-steroidal anti-inflammatory might impair platelet function and exacerbate underlying coagulation disorder. So always ask about recent use within 1 to 2 weeks of this agent, even if they are not the suspected cause of bruises or bleeding, because of platelet function abnormality that caused by this medicine. So this might lead to unnecessary and expensive studies if we didn't ask about history of medication. Also, accidental or intentional ingestion of warfarin containing rodenticide might cause bleeding symptoms in children. In pediatric practice, we come across cases of poisoning with rodenticide, qatil al-hasharat. These compounds usually contain warfarin-like substance, and the child present with a bleeding tendency. So it should be asked for in any child presented with a sudden onset of a bleeding tendency in the emergency room. Clinical features, we should assess whether it is a single site or a bleeding or multiple site. Mostly single site is a local cause, which is not related to bleeding tendency. But if there are multiple sites, this is suggestive of a bleeding disorder. Also, we should look for general condition of the child and his activity, and whether he has any abnormal symptoms like fever, pallor, abdominal distension. Also ask about history of underlying disease like chronic renal disease or liver disease in these children. For example, a male infant who just started to walk present with painful swollen joint after a simple fall is presumed to have hemophilia until proved otherwise, because these joints are small and dependent joints, so they are liable for bleeding with any trauma. Similarly, if the child presents with a prominent forehead trauma in a male infant or young boy, usually it is a common presentation of hemophilia. The same is excessive bleeding after surgical intervention, especially circumcision in males. Other clinical features, for example, a child who presents with petechiae and or mucocutaneous purpura with a recent history of viral infection, he is most likely have acute post-infectious immune thrombocytopenia, while adolescent girl who present with excessive menstrual bleeding with history of recurrent nosebleed and pallor, she might have von Willebrand disease, which is the most common inherited bleeding disorder in 1 to 2% of population. A newborn who present with bleeding from umbilical stump should be always evaluated for coagulation defect. Also, infant or a newborn who present with intracranial hemorrhage without other risk factor also should prompt consideration of coagulation defect. You can see this picture, which was already given to you in the hematology lecture. For example, in a patient with a platelet disorder, as you can see, he presents with a mucocutaneous bleeding like mucous membrane of the mouth, also in the conjunctiva, nose, and GIT, while patient with coagulation defect usually present with the hemarthrosis or bleeding in the joint or soft tissue hematoma. This is another picture also given to you in hematology lecture. You can see the picture on the left showing to you petechiae and ecchymosis, while the right-sided picture show you subconjunctival hemorrhage, which is a serious mucosal bleeding, which might be a herald sign for CNS bleeding. Another boy presented with heme erythrosis and ankylosis of the joint with atrophy of the muscle of lower limb due to recurrent bleeding and destruction of knee joint. This is a typical manifestation of vasculitis disorder, Hinoch-Schönlein purpura, which is due to an inflammation of small blood vessel or capillaries, giving rise to multiple palpable purpura, usually present on the buttocks and lower limbs. What are the tips that should be looked for on examination in a child with a bleeding tendency? We should look for the nature of bleeding, as we mentioned, for example, presence of petechial rash, ecchymosis, mucosal site bleeding, muscle hematoma, deep visceral bleeding. All these are suggestive of different types of bleeding disorder. Also look for associated symptoms like pallor, fever, fatigue and weakness, loss of weight, any swelling in the lymph node or abdominal enlargement due to hepatosplenomegaly. Also look for signs of chronic diseases like renal or hepatic disease. For example, a renal disease, failure to thrive, earthy color, anemia, signs of ricket, acidotic breathing, as well as bruises and ecchymosis due to abnormality in platelet function secondary to uremia. While in hepatic disease, we should look for the presence of jaundice, palmar erythema, spider nevi, capillary hemangioma, the signs of portal hypertension, ascites, and splenomegaly, edema, and so on. Also, we should look for dysmorphic features, for example, anomalies of Fanconi anemia, also mentioned in the lecture, like growth retardation, microphthalmia, microcephaly, absent thumb, absent radius, Kaffir-Olay spot, dark-colored off skin. Also features of Down syndrome. Why? Because Down syndrome is 15 times more liable to develop acute leukemia than normal children. So always look for features of Down syndrome in any child with a bleeding tendency. This is a picture also shown in a previous hematology lecture, showing you a child with Fanconi anemia. He has absent thumb radius, microphthalmia, growth retardation, and microcephaly. Another children with the cervical lymphadenopathy, the one on the right, bulky, big lymph node enlargement with a small lymphadenopathy in cervical region in the left picture. This is also gum hypertrophy, which can be seen in a patient with a bleeding tendency, especially in aplastic anemia due to hyperplastic gingivitis or leukemia due to infiltration by blast cells, especially in acute promyelocytic leukemia. And finally, I will summarize this presentation in this table. So any child presented to you with a bleeding tendency, the history always should include age of onset, site of bleeding, skin, mucous membrane, deep muscle, and joint, duration of the bleeding, and if there is a previous similar attack, severity and correlation with the severity of a trauma, whether spontaneous, after mild, moderate, or severe trauma. Also, general condition and activity of the child, like fever, pallor, abdominal distension, any recent upper respiratory tract infection in ITP, personal history like chronic renal or liver disease, family history of such condition, previous surgery like tonsillectomy, dental extraction or circumcision, menstrual history in adolescent female, the drug history like aspirin, non-steroidal anti-inflammatory drugs. And while the tips on examination, we should look for nature of bleeding like petechial rash, ecchymosis, mucosal bleeding, muscle hematoma, deep visceral bleeding, any associated symptoms like pallor, fever, weakness, loss of weight, any lymph node enlargement, any abdominal enlargement due to organomegaly, other signs of chronic renal or hepatic diseases mentioned already, and finally to dysmorphic features of Fanconi anemia or Down syndrome. I will stop here, and I hope that this brief presentation might be helpful for you from a clinical point of view. Thanks for listening, and I wish you a success in your final exam, hoping that this pandemic will end soon. Thanks so much.